Welcome back, Focus learners, to part 64 of our 100-part CPC exam series. We are cracking the code today on literally one of the most critical, heavily tested aspects of medical coding. But hey, before we jump right into this explainer, make sure to like, share, and subscribe to Decode Healthcare with Harshal. We've got a lot of ground to cover to get you ready for that 2026 exam, so let's not waste any time. So, what exactly is a CPT modifier? Think of it like a little tag, a two-digit numerical appendage that you just tack onto a CPT code. It basically tells the pair, hey, this service or procedure was altered by a very specific circumstance, but, and this is key, the core definition of the code hasn't changed at all. Why does this matter? Well, mastering these is absolutely crucial for passing audits, avoiding those dreaded claim denials, and, of course, acing the CPC exam. To build a solid mental framework for this, it helps to break modifiers down into two main buckets: pricing modifiers and informational modifiers. Pricing modifiers do exactly what they sound like. They directly change the math. They literally affect your reimbursement calculation. Informational or statistical modifiers, on the other hand, don't necessarily change the dollar amount, but they tell a crucial story that helps you bypass those tricky National Correct Coding Initiative, or NCCI edits. Okay, Section 1, EM modifiers. Conquering 24 and 25. Let's dive in. We're jumping straight into our rapid-fire deep dive, starting with the notoriously tricky evaluation and management, or EM, modifiers. You guys know the real struggle here is knowing exactly when to use which one. Conceptually, try to contrast them like this. Modifier 24 is your absolute go-to for an unrelated EM service that happens during a surgical global period. Modifier 25, that one's used on the exact same day as a minor procedure when you have a totally separate significant EM service. Let's look at the specific rules for these. So the rules for Modifier 24 brilliantly highlight a major CPC exam trap. You use this during a 10-day or 90-day global period, right? But here is the golden rule you cannot forget. The diagnosis for this E&M visit must be completely distinct and unrelated to the original surgery. For example, if a patient comes in during their 90-day hip replacement global period for, say, a random sinus infection, you use 24. But if they're coming in for surgical pain, nope, that's bundled, and using 24 there is a massive audit trap. Okay, let's talk about Modifier 25. You're appending this to an EMM code on the exact same day a minor procedure, so a 0 or 10-day global is performed. But your medical documentation here has to be rock solid. It literally has to prove that the provider performed a significant, separately identifiable evaluation that goes way, way beyond the typical pre- and post-op care that's already baked into that minor procedure. Moving right along, Section 2, Modifier 26, the professional component. When you're looking at split billing rules for radiology, pathology, and diagnostic medicine, you'll see this classic split all the time. You've got the professional component, which is Modifier 26, versus the technical component, or TC. For the exam, you want to scam the question for this massive clue: physician read and interpreted only. If the doctor just read the X-ray and wrote the report, but the hospital actually owns the machine, you confidently apply Modifier 26. If the facility is billing for the equipment usage, they're the ones who use TC. All right, Section 3, surgical modifiers, 22, 50, 51, and 52. Now we are focusing on the heavy-hitting surgical modifiers that dictate major reimbursement changes. First up, Modifier 22 for increased procedural services. You use this when the surgical work is just substantially greater than typical. We're talking severe trauma, crazy excessive time, or really complex anatomical anomalies. But beware, tacking this on triggers a manual audit, meaning you need incredibly detailed documentation. And the biggest rule of all, never append Modifier 22 to an E&M code. It is strictly for procedures, no exceptions. Next up is Modifier 50 for bilateral procedures. Pretty straightforward. This is for identical procedures performed on both sides of the body during the exact same operative session. But you really need to pay close attention to the specific scenario on your exam. Payer-specific rules are huge here. Sometimes you'll bill one unit with Modifier 50, but other times certain commercial guidelines might want separate line items with RT and LT modifiers instead. So keep your eyes peeled for that. Let's talk about the maths behind Modifier 51 for multiple procedures. When a surgeon performs multiple distinct procedures in the same session, the multiple procedure fee reduction rule kicks in. It's basically a pricing cascade. The highest valued primary procedure gets paid out at 100%. But any secondary procedures with Modifier 51 appended, those get a 50% payment reduction. Actually, knowing when not to use Modifier 51 is probably just as important. Seriously, never use it on EM codes, and for navigating your CPT book, never append it to add-on codes. Those are the ones with a little plus symbol. Also, never append it to Modifier 51 exempt codes, which you'll spot by that circle with the slash symbol. If you see those symbols on a test question, you can just rule out 51 immediately. Finally, for this surgical section, we need to clear up the vital difference between 52 and 53. Modifier 52 is for reduced services. This means a discretionary, partial reduction by the physician's choice. Modifier 53, on the other hand, is a discontinued procedure, meaning they actually had to stop entirely because the patient's life or safety was directly at risk. Think of it as choice versus safety. Almost done here. Section 4, the high-yield cheat sheet. Get ready to screenshot this. Let's bring this all together and lock in those specific trigger words for the 7 modifiers we just covered. 22 means increased work and trauma. 24 is an unrelated EM during the post-op global. 25 is a distinct EM on the exact same day as a minor procedure. 26 is the professional physician interpretation component. 50 means bilateral. 51 triggers that multiple procedure reduction math. And 52 means the service was partially reduced by choice. Now, you might be wondering, what about the rest of them? Like, what happens when a procedure is stopped for safety? Or what about the infamous, heavily audited Modifier 59 and its highly specific X subsets? Well, that brings us to the end of this explainer, but the journey continues. I'll see you in Part 65 from Modifiers Masterclass Part 2, where we're going to tackle exactly that. But before you go, ask yourself this. If a single 2-digit mistake on Modifier 51 can instantly slash your clinic's revenue by 50%, can you really afford not to master this stuff? Keep studying, stay focused, and I'll catch you in Part 65.